So welcome to today's Let's Code Together session. My name's Jane Knight and I'm joined by my colleague Dr. Caroline Wilson.
Welcome.
The first slide explains that MEDRA came about in the mid-1990s. It was an ICH initiative. The MSSO was put in place to maintain and develop, distribute MEDRA, and the MSSO activities are overseen by a management committee with representatives of the regulatory authorities and the industry across the ICH regions. The second slide is the disclaimer explaining that MEDRA is owned by ICH, as is the material that you see today. So if you quote it or use it in any way, then you must acknowledge ICH as owners and explain the changes. The slides are not made available, but the recording will be uploaded to YouTube. We'd like you to participate. We call this a workshop session, so we would like you to use the questions panel to ask your questions or make comments. We may not all agree sometimes on the term examples, and in this case we may have to agree to disagree just in the interest of time. We can't take your requests to code specific verbatim terms in the questions, not during the session today. However, at the end, there will be an option for you to propose new examples for consideration, but please make these of general interest to the wider audience. And as you'll see, we've included today a number of examples which we have been sent by our attendees at previous sessions. So you may notice one of yours that you've suggested. So this is the polling software. The easiest way to join is to scan the QR code that you see on the right-hand side with your smartphone. But if you don't want to do this, if you wish to use a computer browser, you can type in polev.com, nothing more, just polev.com as the URL in the browser window. Then when you get the screen that you see on the right hand side, it asks for a username, and that's where you need to put my name, Jane Knight 855. And this is the username. This links you to the presentation, and then you can click join. So I'll leave it just for a moment. In fact, I'll do it myself so I can monitor along with you all. I'll do that. There we are, I'm linked up. So the first one, now before we start, I must say I've got an apology here today. There's something changed with the settings of my poll everywhere, and it appears that it's slipping off the screen. The error just appeared just in the final checks before the session, and so I haven't had time to investigate it. So apologies for this. If it becomes too troublesome, we'll switch the presenter role to Caroline. So let's see how we go. In the meantime, I see a lot of you are joining us. Let's see, we've got a lot of you in Europe, a few of you in India. I see Australia, welcome, good evening to you. Somebody in North America, a couple of you there, probably
China.
Our regulars. China, happy New Year to you in China. North America.
Russia, South Korea.
Probably Catherine.
Yes.
Catherine in the US. Perhaps
North Africa, so
North Africa, Korea,
all continents.
Welcome, welcome. It's lovely to see this. Welcome. So here's the demo password for the web-based browser. Caroline's put this in the chat for you. This will only be valid for this week. It will expire on Friday. So if you don't have browser access, take a snapshot of this perhaps with your phone, or you can take it from the chat and you can go to the browser and log on. And I've shown you there on the home page, top right-hand corner, the link for the web-based browser. So as we always say, there may not always be an exact match for a verbatim term. Sometimes there's more than one possible approach, and we'll see that in our examples today. Even the points to consider document sometimes gives us options for coding, and sometimes it's a case that we see a term differently. Our understanding can differ. Caroline and I have that sometimes when we prepare for these sessions. But the best we can do is what we would say is a best approximation. We're choosing the closest LLT that we can find in our Medra browser. And overall, we must always code as reported. We never add information or make assumptions. But sometimes verbatim terms can be really tricky. And we always have a picture and we say, well, how do you see this picture? Sometimes verbatim terms can be like this. I could look at that and see the woman's face, but someone else might look at it and they immediately see two horses running, galloping with some birds in the sky and some birds there which actually make the face of the woman. So medical terms verbatim terms can be like this. You look at it one way and you see one condition, but then you've got a little doubt in your mind. Maybe it means something different. So it's a balance, isn't it, between having rules for coding and using medical judgment to balance patient risk. Medical references can be useful, and sometimes we may even decide to submit a change request, and we'll see that in our examples today for a new concept to be added to Medra. So that's our preamble to this session, and having said all of that, let's code together. And at this stage, I'm going to turn my camera off so it can be distracting, but I'm still here with you all.
Okay, I will
over to you, Caroline.
Yeah. So can you see my screen, Jane? Okay, so let's start with the 4 examples which we carried forward from the last session. Here it is reported that the patient suffered joint pain and stiffness in fingers and knees upon waking. So what is being reported here? First, we have to be very clear about what has been reported here. And we have to ask ourselves if we need to split code, if we have to assign more than one code, and also have to decide on the fact whether the time of the day that is reported here, that is upon waking in the morning, is significant. And what would be the most appropriate LLT here, or the most appropriate LLTs? So which LLT or which LLTs would you select? Would you read the verbatim to mean that the joint information refers to stiffness of both the knees and the fingers? It's obvious for the knees because the knees are considered joints. But can we assume that the reported stiffness and the pain is also referring to the finger joints? Or would you think that the information joint only refers to the pain and stiffness of the knees and not to the fingers? So this is a fairly common scenario, and in normal usage, this information is not repeated again. So the information joint would not be repeated again within an enumeration. And I'm really curious to see how you would approach this issue. So here are the terms that you can choose from: joint stiffness, early morning joint stiffness, stiff knees, fingers stiffness, joint pain, knee pain. Aching in knees would capture plurality so that both knees are affected, or pain in fingers. What would you do? See many votes already. So let us see what you are going for, what you have decided. So we have a split of opinions: joint stiffness, early morning joint stiffness, stiff knees, finger stiffness, joint pain. So early morning joint stiffness and joint pain seems to be the favorite assignments, but we also have other suggestions, like, for instance, fingers stiffness and pain in fingers. Split of opinions here. Let me close the poll and switch to my browser. So let's see what we have in the browser. Here is my browser. First of all, I personally would take our verbatim to mean that the specification joint refers to both the knees and the fingers, so that both the knee joints and the finger joints are affected by the pain and the stiffness. Most of you have also gone for this solution, because this is the usual usage in everyday language, everyday communication. So let us look for our proposed terms. Joint stiffness. Let me look for joint stiff to use some. Here I have a match stiff joint, right mouse click, go to browser, and let's check this PT in the hierarchy. Here we have the joint stiffness, and you see there are some specific terms for ankle stiffness, stiff knees, stiffness hip, and joint tightness also as a synonym for stiffness. And we have the early morning joint stiffness under this PT joint stiffness as well. There's no specific term available for the finger joint stiffness, but we have the stiff knees. This again would capture the plurality that both knees are affected, and we have the option to go to early morning joint stiffness. So what about joint pain? So joint pain, let me check arthralgia, here it is. And you see we have many more options under this PT here. Even laterality can be captured here, left knee, right knee. In our instance, both knees are affected, so aching in knees would be the most specific term for the pain in the knees. And now let us look for any term that would capture the information that the finger joints were affected. And here we have the pain in joint involving hand. So this is the most specific term that we can find for the finger joint pain. There's no specific term for the fingers alone, so it's involving hand. And if we now look for pain in fingers, assuming that the information joint does not relate to the finger or the fingers, and look for the hierarchy, you see that it's completely different hierarchy. It's grouped under pain in extremity. So here's the hierarchy. It's under musculoskeletal SOC as well, but it's under different HLT as well, musculoskeletal and connective tissue pain and discomfort. So this would really change the PT in this instance of if we would assign the pain in fingers. Now let us look for stiff and finger and search. And here we have the stiff fingers, and it's grouped under musculoskeletal stiffness. Again, let us check the hierarchy. Here we are. And it's grouped under different HLT, musculoskeletal and connective tissue conditions, NEC. So this would lead to different PTs if we would not consider the joint information as relating to the fingers as well. So we have now found suitable terms, but we need to ask to what extent split coding is necessary. We know that two different medical concepts were reported, namely joint pain and joint stiffness, because we assume that the joint information refers to both the knees and the fingers. But we do also need to capture the fact that different joints were affected. Let me switch to my slides, back to my slides. Here we are. The meta points to consider document for meta term selection provides guidance for verbatims where a given event occurs at multiple body sites and where all associated LLTs are linked to the same PT. And we are told that split coding would not be necessary in such cases. That wouldn't make sense because you would be duplicating the same medical concept. And because analysis is run on PT level, this would really hinder effective and meaningful analysis of the safety data. You would duplicate events on PT level. In our example, both the LLT early mornings joint stiffness and the LLT stiff knees are linked to the PT joint stiffness. There's no additional specific LLT available for the stiffness in the finger joints. So we could just code to the stiff knees LLTs, but this would mean that only the knees were affected. That's not the case. But by selecting early morning joint stiffness, we capture both the fact that maybe different joints are affected, and we capture some additional information that is medically relevant in this instance, because the fact that the stiffness occurs in the morning really points at specific medical conditions, like, for instance, arthrosis. In this case, I would prefer to assign this LLT, early morning joint stiffness, because more than one joint type of joint is affected. And then we would rather use the joint pain or joint stiffness in this instance. And also with the early morning joint stiffness, we capture some additional information, not only the fact that the joints were stiff, but also the timing of the stiffness. And since the LLT's pain in joint involving hand and knee pain are both grouped, or aching in knees, are both grouped under PT joint pain, they can be coded to the LLT, which is identical to this PT. There's no LLT that would capture the fact that any timing information. And here are our learning points. First of all, make sure to capture all reported information, the joint pain of the knees and fingers, as well as the joint stiffness of the knees and fingers. And when searching for suitable terms, always check the hierarchy. The LLT finger stiffness and the LLT pain in fingers look promising at first glance, but by assigning these terms, one would lose the information that the finger joints were affected. These conditions are considered musculoskeletal signs and symptoms, not joint signs and symptoms. And if you are not sure how to handle such scenarios, always consult the Verbatim Terms selection PTC document or your own coding conventions, of course. So here are our final suggestions. We would code to LLT early morning joint stiffness under PT joint stiffness, and to the LLT joint pain under PT arthralgia. Any questions or comments?
Yes, we do have a comment, Carol-Ann. It says in our verbatim that the pain is upon waking. And how do we know, why have we decided that it's early morning? It may not be early morning. It might be that the person's waking up at noon.
Yeah, but I would always try to interpret verbatims in the usual sense of the wording. So upon waking, for me, usually you wake up in the morning. So in this instance, it's really what it means is that you have the stiffness and the pain after some resting period, and this is typical for arthrosis, for instance.
Yes. So the early mornings part of it means upon waking, then, really, doesn't it? That's the only question, Carol-Ann. Only question.
Okay. Then I will continue with the next example that we have. So our next verbatim describes a 13-year-old girl with spiking fever, a rash, and red swollen joints. Lab tests revealed a positive rheumatoid factor, and based on her clinical signs and symptoms, she was diagnosed with systemic inflammatory arthritis. So do we understand what is being reported? And do we have to capture all information received? Do we have to split code? And what would be the most appropriate LLT or LLTs in this case now? Again, your turn. Quite a number of choices here. So which one or which ones would you select? So Jane has also put this verbatim in the chat. It was too long to include it in this poll here. Systemic rheumatoid arthritis would be an option. Systemic juvenile idiopathic arthritis, systemic onset juvenile idiopathic arthritis, juvenile rheumatoid arthritis, seropositive rheumatoid arthritis. Would you also code the clinical signs and symptoms like swollen joints, redness, spiking fever, the rash, and the investigational finding that was reported, rheumatoid factor positive. So what would you do here? It's a difficult medical topic, but this is something that is often mentioned in the feedback as a topic of interest, because obviously it always leads to some problems in terms of classification. So I see that you are voting, still voting. Now let's look what you are going for. Oops, split of opinion. Some of you would consider this as a rheumatoid arthritis. Others would code to either juvenile idiopathic arthritis, systemic or systemic onset juvenile idiopathic arthritis. Others to juvenile. So everything. You're voting for all of these options. So this is what I really expected, because, as I said, it's a difficult medical topic, and classification is really not easy. So let me close the poll, and let us first check for the potential code assignments that we saw in the poll. So let me start with a search for, first of all, the basic medical concept that was diagnosed is an arthritis. And the other information that we have is that it's not only arthritis, so not only affecting a joint, but it's a systemic disease. And also the signs and symptoms that we saw show that this is a systemic disease, because there's a fever was reported, a rash was reported. So this is also relevant information, that it's not only just an inflammation of the joints, but has systemic signs and symptoms. So let us search for potential hits for this combination. And here we see systemic juvenile chronic arthritis, systemic juvenile idiopathic arthritis, systemic onset juvenile idiopathic arthritis, and systemic rheumatoid arthritis. So let me first check the systemic rheumatoid arthritis. And many of you have voted for these rheumatoid arthritis terms. Let us again go to the browser. Here we are. And we are in the HLT here, rheumatoid arthropathies. And rheumatoid arthritis, you see that there is no mentioning of any systemic aspect. And we also see that in the LLT content of this PT, that the age group is not captured here. There's no term that would contain the information juvenile or adolescent or whatsoever, so nothing. So let us then look at the neighbors here. Here we have a term, juvenile idiopathic arthritis. So here at least we have the arthritis and we have the information juvenile. Let's look into this PT now. And here we have all terms, polyarthritis, arthritic, idiopathic, chronic polyarthritis. So these all are grouped under juvenile idiopathic arthritis, but none of these terms, there's also seropositive polyarticular disease, but none of these terms really captures the fact that it's a systemic disease. It captures the age group, but not the systemic disease. And if we now look for the other term that we saw in our poll, the systemic juvenile chronic arthritis, systemic juvenile idiopathic arthritis, systemic onset juvenile idiopathic arthritis. All these three LLTs are grouped under PT Still's disease. So these LLTs seem to be more appropriate because they do not only capture the basic medical concept, the arthritis, but also the systemic aspect and the age group. And then, of course, we had the related signs and symptoms of this diagnosis. And this was swollen joints, redness, spiking fever, rash, rheumatoid factor positive, all direct hit in MedDRA, so I don't have to show them. And the question is whether we have to split code here. So let me switch back to the slides. And let's first use some references to get more clarity about the diagnosis made. So the professional version of the MSD manual is freely accessible on the internet and is a really helpful resource if you're not familiar with it already. It is available not only in English, but also in Spanish, French, Italian, Portuguese, German, Ukrainian, Chinese, Vietnamese, Russian, and Japanese. So really helpful to use if you're not fully clear about the medical concept, what kind of symptoms, signs and symptoms are related to a given diagnosis, etc. So we can see here that juvenile idiopathic arthritis, or JIA, is not a single disease, but is used for a number of chronic, non-infectious types of arthritis that occur in children and share certain features. The three main types of JIA are the systemic JIA, the polyarticular JIA, and the polyarticular JIA. And one would have to decide what is really oligo, what is poly, yeah, what does this refer to? You also see this in arthritis, for instance, polyarthritis, oligoarthritis, arthritis are three separate PTs in MedDRA. So you have to have clarity about the definitions for these specifications of the articular disease. And I can tell you, if you look into the door lens, for instance, oligo refers to situations where 2 to 4 joints are affected at the same time, and poly relates to conditions where more than 5 or more joints are affected at the same time. So these are, it's worthwhile to put some of these definitions in your coding conventions to ensure really a consistent approach for these classifications. Because, for instance, the LLT arthritis, multiple joints, is grouped under polyarthritis. So, and you should make sure that if you have the number of joints that are affected, you should really make sure that polyarthritis is the correct PT to code to, or whether oligoarthritis would be more appropriate. So these are things that are worthwhile to consider for coding conventions. So so we see this classification here, and we are also told that the distinction between the different entities in this group is difficult. And even when I looked into this and looked for suitable references, I could see that even in the medical literature, the nomenclature for the different subtypes is used inconsistently. So, it's also important to know that sometimes, yeah, children move from different categories during the course of their illness. So they could move from systemic JIA to a different type of the disease. So this is all important information in order to classify our reported diagnosis appropriately. So we also are told that systemic JIA is called still disease. And we have already seen this term when looking into the browser before. Oops. It is a separate PT in the MedDRA hierarchy, meaning it is considered a separate medical concept because of its systemic nature. The full expression of systemic JIA is characterized by fever and arthritis, together with at least one of the following features: a rash, generalized lymphadenopathy, enlargement of the liver and or the spleen, and or serositis. However, the classic features are not always present at the onset of the disease. In addition, the symptoms and signs are non-specific and overlap with other inflammatory and non-inflammatory conditions. Therefore, it is a very challenging condition to diagnose. And however, in our case, we know the patient's age and that she has a systemic disease with arthritis, spiking fever, and a rash. So this means that all criteria for the diagnosis of systemic JRA are met in our case. In systemic JRA, lab values suggestive of systemic inflammation, such as elevated erythrocyte sedimentation rate, the elevation of the C-reactive protein, along with leukocytosis, anemia, thrombocytosis, are almost always present at the time of diagnosis. So systemic JRA is mainly an auto-inflammatory disease. It's not an autoimmune disease, it's auto-inflammatory. However, this publication points out that the rheumatoid factor may be positive in some of these patients during the course of the disease as well. So you see that in this group of patients, of these 32 patients that were all negative, rheumatoid factor negative, at the time of diagnosis, 10 of them developed a positive rheumatoid factor. So they were converted to be seropositive during the follow-up period. And none of them had a positive rheumatoid factor before. So this really shows what we saw earlier here in our definition, that the children may move to different categories during the course of their illness. So this seems to be the case in our example as well. Now, to what extent is split coding necessary in this case? Most of you will probably already be familiar with related guidance in the PTC document for Verbatim Terms selection that you can see here. If we have a definite confirmed diagnosis, the preferred option is to code the diagnosis only and to not code the characteristic signs and symptoms in addition. So here you have an example: anaphylactic reaction with rash, dyspnea, hypotension, and laryngospasm. We would only code to anaphylactic reaction. And we always refer to this preferred option in our trainings. And if investigational results are provided that match with the diagnosis, again, no split coding is required. But we saw in our reference that the presence of rheumatoid factor cannot really be considered characteristic for the diagnosis systemic JIA. It may rather indicate a transition from an autoinflammatory to an autoimmune phenotype of the disease. And based on all these considerations, these are our learning points. In this medical field, it is particularly important to be very clear about the given diagnosis and its signs and symptoms. Therefore, consulting medical literature and dictionaries is really necessary unless you are already an expert in this field. An important factor in the correct classification is the age of the patient. Age must be considered by searching for either juvenile, adolescent, pubescent, teenaged, etc., in order to look for terms that really capture the age group in this instance. And finally, when assigning codes, apply the coding principles from the PTC document we just discussed. So here are our final suggestions for the code assignment. We would code to LLT systemic juvenile idiopathic arthritis under PT Still's disease, capturing the age group, the systemic nature of the disease, and the main symptom, the arthritis. Systemic juvenile idiopathic arthritis and systemic onset juvenile idiopathic arthritis are used synonymously in literature, but we keep our coding as close to the verbatim as possible. We would not split code to capture the reported rash and the spiking fever and the red swollen joints. This is because these are typical for the diagnosis. However, because systemic JIA is more an autoinflammatory condition, we would code the positive rheumatoid factor separately because we would not consider this lab finding to be characteristic of the diagnosis. Do we have questions on or comments, Jane, for this one?
Well, thank you, Caroline. No, I think our group's still taking in. That was a very interesting, complex example there, but covering some points, some basic coding points underneath it all. So we have now got a question. Yeah. Why did you not select systemic onset JIA?
Because it's not mentioned in our verbatim. It's just that I keep it as close to the verbatim as possible, but it would not be incorrect to assign LLT systemic onset juvenile idiopathic arthritis because both are really considered synonyms.
And the second question there from Serene is talking about the MSD manual. Is this something that our group can obtain? How to obtain it? How to use the reference that you showed?
Accessible, freely accessible.
Freely accessible. Good.
Yeah, it's freely accessible on the internet. So if you enter MSD manual in your browser, and there's two versions, one professional version and one for patients. So of course you find more medical information in the professional version. So look out for the professional version of the MSD manual, and you will get a hit. Then you can select your preferred language and can search for certain medical concepts. And it's really complex information that you get there, and for many different medical topics.
And then the last question that has come in, why rheumatoid factor positive is not only coded as a lab test result?
Well, it's a finding. It's a finding. It's not a usual finding that you would find in a healthy person. So it's an adverse event, so to say, not a clinical sign or symptom or diagnosis, but it's an investigational finding that is relevant in this case because it's indicating an autoimmune component in this case, and because of the fact that the Still's disease is not an autoimmune disease, at least at the onset of the disease, it really adds some information for this particular case.
Thank you, Caroline. That's everything in the questions so far.
Yeah, I know it took me quite a long time myself again to really get clarity about this differential diagnosis and what is relevant for the different aspects of this particular medical area. So it's really a complex area, and I think that's why we get the feedback. Correct me if I'm wrong, Jane, but we often got the feedback that some of you would like to have more information about the topic of autoinflammatory disease.
Yes, this was a request. Rheumatology was a request. So I hope the attendee who asked for it is able to join us today. Thank you very much, Caroline.
Thank you, Jane. I give it back to you then.
I'll take over now. So here we are. So staying with that theme, our next verbatim is systemic sclerosis - rheumatoid arthritis overlap syndrome. So what's being reported here? We seem to have two conditions, but we've got this overlap syndrome, which is something we hadn't come across before. So is there more than one condition reported here, or is this one condition? Do we need to split? And what would be the most appropriate LLT or LLTs here? So how would you code this one? I've got a free text for you here, so you can type in, whether you use your browser or you give us an idea of what you'd search for, systemic sclerosis, rheumatoid arthritis, overlap syndrome. Overlap syndrome is our first comment, overlap syndrome. Well, I'd be doing some referencing to see what overlap syndrome means. Does overlap syndrome always mean this? Is that sufficient? Oh, we see we've got consistency here among our group today. Overlap syndrome seems to be the consistent, unanimous response. Thank you for that. So one of you would code all three here. The systemic sclerosis, rheumatoid arthritis, and the overlap syndrome, or just the two conditions. So let's go on and see what Dorland says. I'll go to medical reference. Overlap syndrome is any of a group of connective tissue disorders that combine either scleroderma with polymyositis or systemic lupus erythematosus, or combine systemic lupus erythematosus with rheumatoid arthritis or polymyositis. So there it's comparing it with mixed connective tissue disease, but actually it doesn't list rheumatoid arthritis among that. So the main thing I take away from that it's a combination of two connective tissue disorders. Scleroderma is given in Dorland's as a synonym of systemic sclerosis. It's chronic hardening and thickening of the skin. So when I looked up systemic sclerosis, it pointed me to scleroderma. So when I then did referencing in more widely in the web, I found that there was a concept called scleroderma overlap syndrome. So looking into what it gave as the definition for that, this is a combination of two connective tissue diseases, which include systemic sclerosis, dermatomyositis, polymyositis, Sjogren's syndrome, rheumatoid arthritis. So there's my overlap that I've been looking for. The rheumatoid arthritis together with scleroderma, also known as systemic sclerosis. So it does seem that it's a concept, scleroderma. So I looked at another reference and I found a second reference that did validate it. So now I've got two references. I'm thinking, well, this does seem to be an accepted medical condition. It's a scleroderma overlap syndrome, combining rheumatoid arthritis with systemic sclerosis, also known as scleroderma. So two references makes me think it's a valid concept. So let's go to our browser. Here I am. I'll go to the website and go to the browser with you all. So let's have a look. We've got out. Let's have a look firstly. Let's type in overlap syndrome and see what we get, because most of you were telling me to code to overlap syndrome. So let's find that term, see if there's any more specific terms. Is there anything perhaps that could be more specific to the scleroderma? So we've got overlap syndrome as an LLT. That's the one that you found. The PT is also overlap syndrome. It's under autoimmune connective tissue disorder. So this is the concept seemingly to what I'm looking for, but doesn't specify scleroderma or systemic sclerosis. So then the other ones are asthma related. So there are some overlap syndromes that not every overlap syndrome relates to what I've got reported. There are other types of overlap syndrome. I can see that because there's a skin one, there's an asthma and COPD overlap syndrome. So this makes me think overlap syndrome is more general. I've got more information in my term. Not every overlap syndrome refers to what I've got. So perhaps then it would be useful. So we all know that rheumatoid arthritis will be in MEDRA. Let's have a look. There's our rheumatoid arthritis. Of course, there it is. Rheumatoid arthritis as an exact match. That we can see is, again, it's an autoimmune link there with that one. Musculoskeletal, but a link to the immune system. So it captures the autoimmune. And then either scleroderma or systemic sclerosis is what we've got. So it seems that there isn't a There isn't a specific overlap syndrome for it. There's my systemic sclerosis, PT of systemic sclerosis again with connective tissue. It's under the connective tissue disorders, HLT there. So let's go back. I'll use the back buttons. Let's go back to my overlap syndrome. I found the two conditions themselves. So let's go, there's my overlap syndrome. Let's go to the browser and have a look at it just to double check. There's nothing more specific. There it is. It's overlap syndrome there. It has a couple of specific, or it has the skin overlap syndrome underneath it, but there isn't mine. So based on that, I'm going to go back to my slides now. I haven't been able to find a single term that's an exact match. So when I look in the MEDRA term selection points to consider, it gives us some guidance about when to select more than one term. And when a specific medical concept is not represented by a single MEDRA term, consider requesting a new term through the change request process. And whilst waiting for the new term, select one or more existing terms from using a consistent approach with careful consideration of the impact on your data retrieval, analysis and reporting. So it's suggesting perhaps it's a new concept, and in the meantime, let's select more than one term. So this is what, if we were to request it, here I've done you an example, requesting scleroderma overlap syndrome, and given the placement of it, the suggested placement and the justification. And this is what you would need to do through the web CR tool if you were looking to submit a change request. And this is one that I've entered for scleroderma overlap syndrome. So that's what the points to consider suggested. And the learning points from this is to understand all elements of the reported event. Remember that overlap syndrome can refer to various combinations. We see that both in the MEDRA browser, and we could do that through referencing on the web. And therefore, I would code each specific condition occurring in combination as well as the reported overlap syndrome. And finally, my suggestion would be to code rheumatoid arthritis, systemic sclerosis, which has a PT of systemic scleroderma, and I would also code the overlap syndrome. And in the meantime, we may find that a new, more specific term does get added, either as an LLT under overlap syndrome or as its own PT, depending on what the decision may be. So any questions, Caroline, on that one?
No questions.
Perhaps it was a bit quick. Questions might come in later.
So far, yes.
So far. So I'll move on, and we can always deal with the questions together at the end of this next example. That leaves our rheumatology examples for today. Moving on to something else now. Now we have biopsy of a painful lump at the back of the throat affecting swallowing. So what's being reported here? Is this a neoplasm, a lump? Well, when I look at that term, I see three things. One is the biopsy being reported. One is the lump, the fact it's painful, and the location at the back of the throat. And the third thing is the problem with swallowing, which is happening as a result. So do we need to split code this? And what would be the most appropriate LLT or LLTs? What would you code this one to? Another free text for you now. I'm making you work, not giving you always the multiple choice. What would you code this one to? Somebody's in there straight away. Biopsy of pharynx, using a synonym for throat, pharynx, and also pharyngeal mass. Biopsy lump feeling in throat, swallowing disorder. Lump feeling in throat, that's an interesting term. Throat lesion, a more general term you're suggesting there. Swallowing difficult, a couple of you have mentioned. Pharyngeal mass, again suggested. A couple of you have suggested that. So we're getting a couple of options here. Biopsy is being reported either as a general biopsy or pharyngeal biopsy, which sounds more specific. Swallowing difficult is coming up. But I see that we've got a difference of opinion between either pharyngeal mass or lump feeling in throat. Okay. So some consistency among you, but a couple of different opinions. I'll move on. I think I've allowed you enough time for that one. So I looked at the MEDRA introductory guide with this one for some guidance, because lumps and bumps and masses are notoriously challenging to code because what's actually being referred to by them. So looking in the PT and LLT naming convention section of the introductory guide, it tells me that lump is considered neoplastic, not considered neoplastic. MEDRA terms the word lump is not considered neoplastic. Terms with lump are linked primarily to the sock that represents them. So in other words, they won't be in the neoplasms, benign, malignant, and unspecified sock. Similarly, mass is also considered non-neoplastic. They are also primarily linked to the site of manifestation. So mass terms which have no inherent anatomic site are linked to general disorders. So this tells me that they're not neoplastic. They're considered lumps or masses, and the two are treated together in that section. So let's browse MEDRA now. I'll go back to where I was. Let's have a look with the words we've been given as throat and lump. Lump feeling in throat, but let's have a look at the hierarchy. Some of you gave me that. So that's a sensation of a foreign body. But what I have hesitancy with that is that my verbatim term tells me there is a lump. It doesn't tell me it's a sensation, a feeling or sensation term. I'm having the lump reported in the verbatim and seeing the introductory guide. I would want to code that to the site of manifestation SOC and as it is an actual lump, not just a sensation. So that would be my hesitancy in using your suggested term there. Let's have a look for mass with throat. No mass in throat. So doing what some of you have already done, you've thought about a synonym for the site of throat. I'll just put pharyn in case it's pharynx or pharyngeal. I'll just put the stem. Let's try with lump first of all. Lump in pharynx, pharyngeal lump, no. So let's again do the synonym search. Pharyngeal mass. Some of you found a term. There it is. Pharyngeal mass is the PT. And that I would feel more comfortable with that because it's capturing an actual entity of the mass and not just the sensation. A pharyngeal mass, and it's in the upper respiratory tract disorders, as we were told, not in the neoplastic SOC. So now I need to capture my biopsy. So let's try with pharyngeal biopsy. Let's try to see if I can find one. Some of you suggested there was a term. So there it is, biopsy pharynx or pharyngeal biopsy. Either of these have got the biopsy pharynx as the PT. So that would be capturing the most specifically the biopsy of the pharynx. I know we're biopsying the lump, but I'm happy with that. And then the other one is the difficulty swallowing. Now let's go with the swallowing difficult. Just I'll put the stem of the word in. Swallowing difficult. There it is. Dysphagia. And it's a gastrointestinal sign and symptom. There are other terms that are tumor related, but remember my term is not treated as being neoplastic. So I'm not going to use a tumor term because that would be a neoplasm. So I will go for swallowing difficult under the PT of dysphagia. And dysphagia to me includes pain. To me, that's a symptom of the dysphagia, so I won't look for a separate pain term, although it said that the pain, the lump was painful. And there's one thing I want to show you here before we, let me just show you something, the fact that I'm going to show you here, lump and biopsy, other terms in MEDRA. So when I was doing preparation for this, I found there was an LLT of breast lump biopsy as a whole LLT, but I couldn't find a pharyngeal lump biopsy in MEDRA, and that's why I've split code it. But look at the breast lump biopsy actually links to a PT of biopsy breast. That makes me think that it's fine for me to choose biopsy of pharynx, because the breast lump biopsy, even though it's the lump that's being biopsied, not the pharynx itself, I'm happy with that. And it's supported by the placement of other similar terms in MedDRA. So those are the terms I would be selecting there, the lump or mass, the biopsy, and the swallowing difficulty. So I would code both the lump and the impact on swallowing. Pain is a symptom of the lump, and that, as I explained, for me it's covered by the coding of dysphagia, and don't assume a lump is a neoplasm or a tumour, nor that it's benign or malignant. We never make assumptions like that. So our final suggestions become pharyngeal mass, pharyngeal biopsy, as you gave me. Well done, those of you who had that, and swallowing difficult. Many of you had all three terms at the outset before we explained it. So well done. Give yourselves a pat on the back for that one. Any questions, Carol-Ann?
Not so far, so it seems to be fully clear.
Good. So
Jane.
that's my two examples. I'll hand back to you, Carol-Ann, at this point.
Yes, I will take over sharing. Show my screen. Here we are. So here we have the next example, and one topic that is often mentioned as topic of interest by our attendees are terms which include information about laterality. We have selected a few of them for our discussions today, and here's the first one, where left knee arthrosis is being reported. So what does arthrosis mean? Do we know what arthrosis means? Do we need to seek clarification here? And what would be the most appropriate LLT? So do you think that the left or right information is relevant in this case? That laterality information is important. Do we need to take it into account for coding? What do you think? So most of you are going for it, that it's not relevant. It's of course relevant for the patient, but in the medical sense, it's not relevant. And we will see that later on in the browser that it's not captured in any of the LLTs that are relevant for our case here. So here, the left knee arthrosis, the information left, the laterality information is not relevant. So how would you code left knee arthrosis? What would you do? Would you assign LRT knee osteoarthritis? Would you select OA knee, so the abbreviation for osteoarthritis? Would you select GON arthrosis or knee arthropathy, or monarthritis, capturing the effect that only one joint was affected? Or would you select a more specific LLT, like for instance, osteoarthritis localized, not specified whether primary or secondary? What would you do? Now let's see what you're going for. Most of you are going for knee osteoarthritis. Some vote for knee arthropathy, monarthritis, GON arthrosis. So again, we have a split of opinions, but most of you are going for knee osteoarthritis. Let me close the poll and let's first look into the door lens again to get more clarity on these medical terms. And you see that arthropathy is, this is clear. Arthropathy relates, it's a general term for any unspecified joint disease. And the next definition really surprised me. Arthrosis is considered a synonym for arthropathy. So it's also considered as any joint disease, as any unspecified joint disease. And we have to remember that Dorland's is, of course, an English medical dictionary. So arthrosis and arthropathy are considered synonyms. Arthritis, of course, is a different medical concept. It relates to inflammation of a joint, and we had an arthritis example with our juvenile systemic arthritis before. And here the definition of the other two medical terms used in our pause suggestions. Osteoarthritis. Here it's a non-inflammatory degenerative joint disease, mainly in older persons, and it relates to the degeneration of the articular cartilage. It also includes hypertrophy of the bone, so it's not only affecting the joint, but also the bone, the margins of the bone. And the symptoms are pain, usually after prolonged activity, stiffness, particularly in the morning, we had that before, or with inactivity. And osteoarthrosis is considered a synonym for osteoarthritis, and this is in line with what we saw before. Now, you may wonder why, depending on your native language, why arthrosis is considered a synonym for arthropathy. This is because the medical term arthrosis is interpreted and used differently in different languages. And here again, some examples from the MSD manual. I told you before, it's available in different languages. So here's the Spanish, a screenshot of the Spanish version of the professional MSD manual. Arthrosis, enfermedad articular degenerativa, meaning degenerative joint disease. And it's considered, so it's considered a synonym of degenerative joint disease. In the German version, Arthrose, again, it's considered a degenerative joint disease, degenerative Gelenkkrankheit. And also again, synonym would be osteoarthritis. And in the English version of the manual, we see the same guidance as we saw in the Dorland's. So osteoarthritis is a degenerative joint disease. Synonyms are osteoarthrosis or hypertrophic osteoarthritis, but arthrosis is not considered a synonym of osteoarthritis. So in such cases, MEDRA will choose the prevailing use of the term and then classify accordingly. This is not really a rare situation. Often medical terms are used differently in different regions with different languages. So this is just one example. And this, of course, always poses problems for MEDRA, and the approach that is taken is really that the prevailing use of the term is used for classifying such conditions. Now let me show you in the browser. Again, here we are. So if I go, we are in the musculoskeletal SOCS still here. Let me close this HLT and the joint disorders. Again, look into the joint disorders. And if we go to the arthropathies, NEC, not elsewhere classified, we see the arthritis. Here we had the monarthritis. The monarthritis is grouped under arthritis. Here it is, but we know that arthritis is, of course, a different medical concept. It's an inflammation of the joint. It's not reflecting degenerative joint disease. I already told you that this arthritis needs to be differentiated from polyarthritis and oligoarthritis, so important to make your coders aware of the differences there. And if I now, so this is something, we have all the arthritis terms here. We have, now let us look for the osteoarthropathies, where not only the joints are affected, but also the bone. And here's our osteoarthritis. So here, let us look into this PT, and what we find under this PT is the LLT arthrosis, because this is considered a synonym of osteoarthritis in MedRA. It's classified as such because of the prevailing use of this term. It may confuse some MedRA users who are native speakers in English, but this is the reason for this classification, that this term is really used differently, classified differently, interpreted differently in different languages. So, do I have any term here about the laterality? We have different localizations: hand, hip, erosive, elbow, localized osteoarthritis, hip, knee, toes, anything you want, knee and knees, so singular, plural is captured, but there's lower leg, upper arm. You see a lot of terms are available, but nothing that would relate to left or right. So again, such a term would not be added to MedRA, because in a medical perspective, it doesn't make any difference. It's an osteoarthritis, and there's no difference in the medical concept when we know that this is affecting a left or right knee or hand joint whatsoever. So what do we have? Do we have the knee? We have knee. What do we have for the knee? OA knee, so we don't have any abbreviation. We always try to be as close to our verbatim as possible. We have the knee osteoarthritis, but what we have reported is an arthrosis. So we would need to find a term that relates to the knee and includes the information arthrosis. So do we have something knee osteoarthritis? Do we have the arthrosis? We only have multiple, and arthrosis NOS, ankle. So what is available, and this is the medical term here, is GON arthrosis. GON relates or reflects the knee. So the knee arthrosis is reflected by the LLT GON arthrosis. So this would be the closest term. You could, of course, also, if you're not familiar, that GON is a synonym for knee, you could also search osteoarthritis knee, but this is closest to our verbatim, and this is what we always try to do when coding, to code as close to the verbatim as possible. So because of the fact that the classification excuse me, of arthrosis may be confusing for some MedRA users, depending on their native language, a related clarification was added to the MedRA concept description. And here you can access the MedRA concept descriptions. These are not definitions, just explanations how medical concepts are classified in MedRA. And if I look into the A here, they're sorted alphabetically, you will find arthritis, arthrosis. In MedRA, any inflammation of a joint is considered arthritis. In contrast, arthrosis is interpreted as a non-inflammatory degenerative joint disease and is linked to PT osteoarthritis. So this is what explains why the arthrosis is classified as we just saw. And it's based on the fact that this is really the most frequent interpretation classification of this term when looking into all MedRA languages. Let me switch back now to my slides. Here we are. This is just a reminder of the concept description that we just saw. And here are our learning points. Because the different types of arthritis, osteoarthritis, and other osteoarthropathies represent a complex group of diseases, it is especially important to become familiar with the definitions of terms and the associated differential diagnosis, because they are often reported. to achieve consistent coding output, it is advisable to document basic rules in your coding conventions, such as when to classify joint disease as poly or generalized or oligo. I mentioned this earlier when discussing our example of the juvenile systemic arthritis. And you should also provide related training to your coders so that you achieve a consistent classification of similar terms. And here we would go to LLT gonarthrosis under PT osteoarthritis. Any questions or comments, Jane?
Yes, Caroline, there's a comment about why you've selected the gonarthrosis and not monarthrosis. Was there a term monarthrosis or was it monarthritis?
It was monarthritis, but even if we had the monarthritis, we had this discussion when I was still working in operational coding or responsible for operational coding. And you know, when you are coding out of context and you have no access to the case narrative in pharmacovigilance, for instance, then you don't know whether only the knee was affected. So we were quite hesitant to make a classification as mono or whatsoever. You can do so if you have the full information of the case, and if you know that you could assign monarthritis, for instance, for an inflammation of the joint, if from the narrative it's clear that only one joint is affected. But in order to achieve consistency, you would have to prioritize, and you should really document your prioritization rules, whether you would in this instance code to monarthritis, or if you would try to capture the affected joint like the knee arthritis. All of this whole area, because also MedRA is very granular in this area, it really needs coding conventions to provide guidance to the coders and also to achieve consistent usage of the available MedRA terms.
Thank you, Caroline. Thank you. Mm-hmm. When I was working coding, we had similar guidance to yours, what you said as well. That's the only question we have on your example. We've got one going back to the lump, the dysphagia example, but we'll come to that at the end, I think. So carry on with your next example and we'll cover the questions outstanding at the end.
So again, an example for laterality information. A weak left arm and left leg is reported here. So do we understand what is being reported? Is laterality relevant here? And do we need to split code, and what be the most appropriate LLT or LLTs? So what would you do here? What would you think? Is it relevant here? Laterality relevant? Most of you are voting yes, but some of you think it's not. Okay, let me close. So we have split of opinion, but majority is voting or thinking that this information here, the laterality information, is relevant from the medical perspective and of course also for coding decisions. So let's look at some options to code this verbatim. Which of them would you assign? Weakness in extremity, weakness of limbs, generalized muscle weakness, limb paresis, hemiparesis, unilateral weakness of limbs. What would be your choice? See you voting. Quite a number of you have voted already, so let me check. Most of you are going for unilateral weakness of limbs. It's closest to the wording. I fully agree. We have the weakness, and we know it's two limbs that are affected on the same side. It's the left side, so it's a unilateral weakness of the limbs. Some of you are also voting for hemiparesis, and some for the weakness terms. But remember, try to capture as much information as possible when coding. So we have information here about laterality and that the left arm and the left leg is affected. So the unilateral weakness of limbs really would provide or would best reflect what has been reported here. Let me close this and again switch to the browser. And if I go or search for muscular weakness using word stems, eye muscle weakness is not, oops, SOC are limited, clear selection. I did not, seems I have clicked something I didn't want to. So here we have many hits, and here we have muscle weakness. So let me go to the browser again. We are again in the SOC musculoskeletal, and here we have the muscle weakness. Again, lots of options here. Asymmetric muscle weakness of lower limbs. This was not the case here. We have a symmetric muscle weakness, descending, lower, localized, hands, lower limb, upper limb, neck, arms, limbs, upper extremities, nothing that would include left arm and left leg. So let me look for hemiparesis. Oops. And search. Here we are, direct hit, go to browser. Let's look for the LLTs underneath. Here we are. Hemiparesis, left and right. So we have, and also the weakness left or right side is grouped under this PT plus the unilateral weakness of limbs. So the weakness does not have to affect the whole side, even if only the limbs are affected of one side, either right or left. This would be classified as hemiparesis based on medical considerations. So you could now code to the unilateral weakness of limbs, being as close to the verbatim as possible, or based on the fact that this LLT is grouped under hemiparesis, you could also decide to capture the laterality as well and code to hemiparesis left. These would, or muscle weakness left-sided, would be the other option. But we know that it's not the full side that that is affected by the muscle weakness. So unilateral weakness of limbs would be closest to our verbatim. So we see that in this area, in all paresis and paralysis terms, the information on laterality, of course, is relevant. And most of you already agreed with me in this respect. When searching MedRA on PT level, for PTs which include the information left or right or unilateral, you get quite a long list of terms, mainly describing cardiac conditions, as you can see here. Cardiac ventriculogram left, abnormal, normal, or really cardiac conditions. These would be investigational findings or medical conditions like left atrial hypertrophy. So these are all cardiac conditions. And of course it is here then it's really important to capture the laterality information, as you can see, because whenever something is represented on PT level or distinguished on PT level, then it's really medically relevant to make this distinction. Also for some unilateral terms which refer to, e.g., special senses, this is really important, like for instance unilateral blindness or unilateral deafness. So for these conditions, it's really relevant to make this distinction, left, right, and unilateral. It's relevant for the cardiac conditions, it's relevant for the special senses, where it's really relevant to know whether the blindness is unilateral or affecting both eyes, and the same for the deafness. And when searching for PT names, which include the string hemi, you can see that most of them relate to neurological disorders, and there are quite a number of them, in addition to the PT that is relevant for our case, the hemiparesis. Capturing laterality information for conditions like anesthesia, dysesthesia, paresthesia, paresis, etc. is medically relevant and has to be considered when coding. So this means that when coding verbatims that contain laterality information, coders need to be aware that the relevance of this information to specific medical conditions like cardiac or neurological disorders or special senses. Training is required to ensure that this is handled correctly. And when dealing with similar verbatims, one should search MedRap bottom up and top down to make sure that such terms are coded accurately and as specifically as possible, using synonyms for the laterality information like unilateral, hemi, etc. And here is our final suggestion. We would code to unilateral weakness of limbs, being as close to the verbatim as possible under PT hemiparesis. And just an additional comment, what would you do if only a weak left arm and leg were reported? So no repetition of the left information, weak left arm and leg. A similar scenario to our verbatim joint pain and stiffness in fingers and knees upon waking, discussed earlier. Would you relate the laterality information given for the arm to the leg as well? You see, it's difficult to come up with a clear rule for this, because here laterality information is medically relevant and we have very specific coding options to choose from. So you'd better consider asking to be as query to ask for the background whether the left is also referring to the leg, to be on the safe side here. Are there questions or comments, Jane?
That's an interesting one, that one, Caroline, because I would take that as left arm and left leg without even thinking. But you're right, it's an interesting comment. No comments on this one. No, we've got a couple of comments on the pharynx, but no other questions on this one. So I think you've got one more laterality example, haven't you? Do you want to do that one in the time we've got available?
I will speed up a bit. Here's the next one. Swelling chest wall, right side. Again, laterality information. So what does swelling mean here? Do we need to see clarification? And what would be the most appropriate LLT? And again, your turn. How would you deal with this verbatim here? Swelling chest wall, right side. Would you consider this to be a chest wall tumor, chest wall mass, chest wall cyst, skin edema, skin swelling? Would you consider LLT nodule subcutaneous or the LLT local swelling? What would you do with this one? Swelling chest wall, right side. So we have quite a number of votes already. So some of you are going for chest wall mass or local swelling. These are the favorite options. Fully agree. Chest wall cyst would be too specific. A cyst is a very clearly defined condition. Skin swelling could be an option. We'll see. So let me close this poll and look into the Dorlans again. What is swelling? So swelling relates to a transient abnormal enlargement or increase in the volume of a body part or area, and it's not caused by the proliferation of cells. The term tumor is used in two ways: as a synonym for swelling, or it could also describe a new growth of tissue, a neoplasia. The term nodule describes a small node that is solid, so it must be small, solid, and it can be detected by touch, or may also relate to an imaging finding of the lung. This is not the case here. We know it's on the chest. On the chest, wall, so it's not the lung that is affected, but it could relate, if it's not specified as in our verbatim, it could also relate to an opacity that is less than 30 millimeters in diameter in an imaging finding of the lung. And last but not least, the term mass is used to describe a cohesive lump of material such as tissue or cells that adhere to each other. So based on the door lens, rather a more solid, finding of representing a mass. No further guidance can be found in the MEDRA concept descriptions here, but in the PTC document for MEDRA term selection. And it is important to understand that in MEDRA, terms containing the string tumor always refer to neoplasia. And Jane mentioned this before when talking about the lump in the pharynx. While terms such as lump and mass are used more vaguely, these are not classified as neoplasms. So let me shortly show you in the browser again. Oops. Here we are. So, of course, we have specific terms for all these options that we saw in the poll. Chest wall tumor is available. Here we are. But as you can see, it's grouped in the neoplasm sock based on the classification in MEDRA. So, no way to go to chest wall tumor. Chest wall mass. Here we are, is grouped under the same PT, chest wall mass, and under musculoskeletal and connective tissue disorders, SOC. So if we look for mass terms on PT level, we see that there's quite a number of them, of course a very general one, and 74 mass terms like abdominal mass, implant site mass, hepatic mass, they are represented on PT level. Chest wall cyst is also available. Here we are, grouped under benign musculoskeletal and connective tissue neoplasms, as because cysts are considered as neoplasms. It's too specific. It's not reported to be a cyst, so we don't know what this what condition is causing the swelling. It would be an interpretation, and the same holds true for skin edema. Is of course available. Here we are. We again go to the skin edema. Go to browser. Of course, it's grouped under SOC skin. Here we are, skin edema, and it's a abnormal large amount of fluid in the intercellular spaces of the skin or the subcutaneous tissue, but it may be localized, yes, like in our case, and result from venous obstruction, lymphatic obstruction, or increased vascular permeability, for instance. But this again would be an interpretation. We don't know whether the skin was affected. It could be that the swelling resulted from a bone rib fracture, for instance, or a muscle swelling, a muscle condition. We don't know. And skin swelling is a separate term, of course, because edema is a more specific term than swelling. Here we are, skin swelling under the same PT. So the verbatim does not indicate that the skin or the subcutaneous tissue is swollen. Again, it would be an interpretation. And nodule subcutaneous would also be too specific. As we saw in the definitions in the door lens, we have no information about how large the swelling was and whether it was small, hard, and palpable. So again, it would be an interpretation. And local swelling, this was the last option that we had in the poll. Here we are. This is grouped under swelling. go to browser. In general disorders, SOC, so a very vague term, but this is exactly what has been reported here. We don't know what really caused the swelling, what structure in the chest wall has caused the swelling, and that's why local swelling would be the best approximation to our verbatim here. Here we are. So we saw that there is no combination term in MedDRA that covers both the swelling and the affected body site. So how can the information be prioritized? Again, the PTC document for MedDRA term selection is helpful because it addresses combination terms that include information about a specific event, in our case, the swelling, and the affected body site. And it recommends giving priority to the specific event if no combination term is available. However, we are told that medical judgment is required and that in some instances, the body site information may take precedence. For instance, when it comes to reactions at administration sites, as you can see in this example here, the cyanosis at injection site should not be just coded to cyanosis because this would lead to completely different interpretation of the condition in the patient, but should be rather coded to injection site discoloration in this instance to make clear that this is the local reaction at the injection site. We would, of course, always try to capture both the specific event and the affected body site and look for an appropriate combination term. The PTC document provides some flexibility in handling such combination terms, and you could argue that the word swelling is quite a vague medical term that could be replaced by a quasi-synonym like mass to capture the affected body site. And as several of you, many of you have gone this way and have selected the mass term in our poll. But such rules and their rationale must be clearly documented in your coding conventions. First of all, to instruct your coders, but also for transparency and inspection readiness. So with this, we would rather prefer to take a conservative approach here and code to LLT local swelling. But depending on your coding conventions, you could also decide to code to LLT chest wall mass, as I mentioned earlier. So many of you have voted for this LLT. But if you decide to do so, then document your rules in the coding conventions so that you take a mass term if you have no swelling term for the affected body site, if you cannot find a combination term in MedDRA for the affected body site. So our verbatim is quite vague, but would you approach such information differently if, for instance, a swelling on the leg or on the arm or on the face is reported? Would you then rather consider such findings as cutaneous or subcutaneous conditions? For example, an infection on the abdomen or on the upper arm, would you classify those as skin infections? So this is another aspect that you may consider for your coding conventions, to add to your coding conventions. So with this, any questions or comments here, Jane?
No questions on this one, Caroline, no.
Okay, then I hand it back to you then.
Thank you. We have had a couple of comments. We've had a comment about Dorlands. How do we get Dorlands? Is it a free one like you showed with the Merck? And I've explained that no, it's a paid subscription one. Then we've also had a request. Can we cover the progression of disease, cause of death, progression of disease? I don't know. What do you think, Caroline? Do we need to wait till next time, or would you be happy to stay?
I think so.
We have to wait for next time. Okay.
Yeah.
Sorry. So, okay, we'll wait for next time. 21st of March is our next session. And then let me just find the wrap-up slides. We've got your survey here for us to do. For you to do. I'm just going to the end. Right, so Let me.
Are you sharing screen, Jane?
I'm getting there. I'm getting there. I was just getting to the right. Here we are. I wasn't sure where we were going to go next. So now I should be sharing. Am I sharing?
Not yet.
Okay.
Yes.
Here we are. So this is just as a reminder to you all, we do these sessions every 2 months now. And our next session is the 21st of March. This is number 19. So there are 18 previous sessions that you can see recorded on our YouTube channel. If you go to the MSSO Medra website, there's an index of all the verbatims that we've done, and you can search it by topic as well as by the date of the session. So if you're interested in a particular topic, for example, renal or musculoskeletal, you can have a look in the index and it'll tell you all the terms that we've covered over the duration, over the since we started these sessions. Also the US sessions too. So that's the YouTube channel. You can see our playlist as well as the playlist of our US colleagues. This is the survey that we mentioned. This is where you put in suggestions, and I really am very sorry if you gave us a suggestion, if you gave us the suggestion of the disease progression or any of the others. We will cover them, but they will be on the 21st of March. We'll pick up on the 21st of March where we left off today. So Carol Ann and I do a lot of preparation for these sessions, but it's difficult to get it practiced to the time available. So we are sorry about that. It varies how many we get done in a session. I feel I've given you all the work today, Carol Ann. You've done the bulk of the work, so I'll make it up to you on the 21st of March. So here's the survey. So if you've got comments, please do let us have your comments. Remember, if you were here for the whole session and if you logged on with your own name, you'll be eligible for a certificate. If you weren't here for the whole session and if you used somebody else's link to log on, then we're not able to give you a certificate. And the certificates will be available in 2 days to download from our website if you go to the self-service application. So I think that's everything. Anything else, Carol Ann, to cover?
Just to say sorry that we did not cover all, but this is really also dependent on the questions that we get and the explanations that we provide in addition. So it doesn't make sense for you if we just rush through those examples. No. So that's why sometimes it's really difficult to estimate how long it will take to go through such an example. That's why we sometimes do not cover as many as we would like to.
We covered some good principles today, some practical principles you can apply to other examples. I enjoyed the examples and I'll look forward to finishing them in March. So we were a little bit over time. Apologies for that. Thank you, Carol Ann, for your collaboration. It's always fun to work with you on these.
Yeah, thank you to you, Jane, as well.
And thank you to everyone for joining us. Sorry it's so early for some of you. And enjoy the rest of your day, everyone. I hope to see you all in March. In the meantime, stay safe and have fun. See you soon, all of you. Bye for now. Bye-bye.
Thank you all. Hope to see you soon. Bye.